Good afternoon and welcome. We're going to get started here. My name is Deborah Gonzalez, and I'm the Government Affairs Director here at PPIC, the Public Policy Institute of California. And I want to thank you for joining us today on Tax Day. I'm sure you all had a great weekend. My husband and I spent some time around the kitchen table, and we did not enjoy it. So I just want to say that. I love my husband. It's not about my husband. For those of you who are not familiar with PPIC, we're a nonpartisan, nonprofit think tank with offices in San Francisco and Sacramento. PPIC recently released a report titled Emergency Department Use in California, Demographic Trends and Impacts of the ACA, authored by Shannon McConville, Carolyn Danielson, and Renee Shaw, all of whom are here with us today. And you will be seeing each of them at a different point in our program. You should have received a copy of the report on your chair. The report, along with the slides that you will see during the presentation, are both available online at ppic.org. We'd also like to thank the PPIC Corporate Circle and the PPIC Donor Circle for their support of this event and for our lovely lunch. For today's program, you're going to first hear from PPIC Senior Research Associate Shannon McConville, who will present the main findings from the report. Then PPIC Policy Director and Senior Fellow Carolyn Danielson will moderate a discussion with a fantastic panel. And then finally, we'll have some time for questions and answers. We are recording this, so when you ask your questions, please wait for the microphone to come to you. You should have also received an agenda on your chair, and all the speakers' bios are on the back side. So in the interest of time, we'll only do brief introductions today. And please note, we love our surveys here at PPIC, so you will receive a survey, an online survey, and we hope that you'll respond to that survey because we do adjust our programming accordingly. And lastly, please turn off your phones. Normally at this point, I make some brief and very witty remarks, but I'm not going to do that today because I know we have such a wonderful panel and we want to have a lot of time with them. So I'd like to now introduce Shannon. Her research interests include health access, utilization, and outcomes among vulnerable populations, and the impact of vocational training programs on economic mobility. Please welcome Shannon.
Thank you, Deborah. And thanks to all of you for coming today. I wanted to first again acknowledge my co-authors who are here, Caroline Danielson and Renee Shaw, and our panelists who will be joining us. And I also wanted to thank OSHPD, the Office of Statewide Health Planning and Development, who provided the hospital discharge data that made this research possible. So let's see. Great. Okay, thank you. So hospital emergency departments, sometimes emergency rooms, ERs, these are all kind of used interchangeably, but they serve as a really essential access point to medical care for all Californians. They're required by federal law to provide screening, stabilization, and necessary medical care for people who present at the emergency department, and that's regardless of whether they have insurance coverage or whether they have the ability to pay for the services that they receive. As a result, hospital EDs are often referred to as the safety net of the safety net. They've long been a focus of policymakers, health plans, provider groups, hospitals, for a lot of reasons. One of the primary reasons being is that care provided in emergency departments it's a more expensive setting to provide care, particularly for conditions or things that could be treated in other outpatient settings. As a result, ED use for certain conditions that are considered avoidable or possibly preventable are often used as an indicator of a lack of access for communities to having timely access to other outpatient care resources. And while ED use has long been a focus for kind of this broad group, the implementation of coverage expansions under health reform, the Affordable Care Act in 2014, I think really renewed some concern or raised questions about how coverage expansions could impact emergency department use. On the one hand, you can think insurance coverage could reduce ED use by providing people with more access points to medical care outside of the emergency department. This may be especially true to the extent that people who gain coverage get connected to primary care physicians through managed care plans, which is true for most of the people who gained Medi-Cal coverage in California under the ACA expansion. On the other hand, coverage typically reduces the out-of-pocket costs that patients face when they access care through the emergency department. And so in that regard, if it costs less and you're not billed as much or at all when you seek care at the emergency room, that could increase ED use. And so I'll say that the kind of evidence base going into the coverage expansions was a bit mixed as to what impact we would expect it to have. And so that's why we wanted to kind of do this deep dive into the trends that we've seen and an analysis of what the impact of ACA coverage expansions meant for ED use. Let's see if I can get this right this time. So we're going to start just with some broad trends in emergency department use. What you can see is that in general, ED use has been steadily increasing over the past, say, decade and a half. The bars show the trends in the total number of ED visits at all licensed hospitals in the state between 2005 and 2016. So those are total visits. So you see at the beginning of the period, total ED visits were around 10 million visits in the year. In 2016, that had increased to about 14.5 million total ED visits. That's an increase of about 40%. The orange bars there are what we call outpatient ED visits. These are emergency department visits where the person was treated and released the same day. The smaller teal or green bars, those are the number of visits where the patient was admitted to the hospital. So they came to the emergency department for treatment, and they were the decision was made that they needed to be admitted for inpatient care. So these are just trends in the total visits, and you see most of the growth has really been in these what we call outpatient ED visits rather than it's been pretty steady, the number of visits that resulted in a hospital admission. It's also increased even when we control for population growth. That's what that line is doing. And then the axis over here is kind of your per capita ED visits. And so we've seen per capita ED visits increase from about 28 visits per 100 people in 2005 to more than 37 visits per 100 people in 2016, an increase of about 30%, again, once we've adjusted for growth in population. And so here we're looking at the same, again, per capita ED visit rates, but we're breaking it down now into more demographic groups. And so what you can see here is on a per capita, so we've adjusted these by the size of whatever population that we're looking at. We see that women age 19 to 34 have the highest visit rates amongst everyone, including seniors and children under 19. This is at least in part related to childbearing and pregnancy. About 1 in 7 emergency department visits for women age 19 to 34 are for pregnancy-related conditions. So you also see seniors have relatively high visit rates, not surprising given as you age, your health tends to deteriorate and you do use more medical care. Children are kind of right there in the middle, and a lot of ED use amongst children is really driven by young children under age 5, and in particular infants have very high ED visit rates. In our analysis, we're focused primarily on the non-elderly adult population, those adults 19 to 64 who really were kind of the target group for the coverage expansions under the Affordable Care Act. And what you see there is their use has increased. Men, non-elderly men are the lower bars. You don't see much difference between those 19 to 34 and the 35 to 64 group, but they have increased about 35%. So kind of across all of these groups, the trend is increasing ED visit rates. And so now to shift gears a little bit, so we've looked at per capita visit rates, which don't take into account the fact that some people use the ED more than once in a year, and for some they use it several times in the year, while many other people never use the emergency department. And we rely generally on per capita visit rates where we use some sort of population denominator because the number of visits is kind of a very accessible measure that we have, whereas connecting things at a patient level tends to be more difficult. This figure actually is is taking more of a patient perspective where we've linked folks across time, across the year. This is for 2016. And so what we're doing here is this is the left-hand bar is the percent of patients, and then that connects to their share of all emergency department visits. And so what you see here is about 2/3 of all ED patients are responsible, make only one visit in a calendar year and are responsible for about 1/3 of total ED visits. I should also note that because we're using discharge data, this only includes people who have ever used the emergency department. We're not using survey data where we also observe people who never use the emergency department. So there are no folks in any of these charts that never use the ED, right? So we see about 2/3 are responsible for about 1/3 of all visits. And then if we kind of hop to the top of the chart, you see about 10% of ED patients make 4 or more visits in the year. They're responsible for about also 1/3 of ED visits. And then if we look at what, this very small sliver, these are the 1% who make more than 10 visits in a year are responsible for nearly 11% of all visits, which is just to say that there is this there's a group that makes a disproportionate number of the ED visits that we do observe in hospital emergency departments. And so here, this is kind of to show you how things have changed in terms of who pays for emergency department visits or the expected payer. So this is the share of ED visits, again, focused on outpatient ED visits among non-elderly adults aged 19 to 64, and it's showing the trend over time in the share of their visits that are paid for by different payers. And so the big thing you see is prior, in the years prior to 2013, the share of visits that were considered uninsured or made by uninsured people was nearly 30% and above the share that was covered or expected to be covered by our state Medicaid program, Medi-Cal. You can see there was a big shift there. Medi-Cal was around, again, 25% through this period. And again, keep in mind, these are non-elderly adults who gained access. And now after that period, Medi-Cal covers about 50% of all ED visits amongst this group, and the uninsured has dropped down to about 10%. So for Medi-Cal, it's about a 20 percentage point increase in the share of ED visits for this group. And for the uninsured, it was an 18 percentage point decrease in the share of visits. So in many ways, those that were likely uninsured have now gained coverage through Medi-Cal. And I just say to a certain extent, there is research that suggests the result of at least having some payer source in this lessened number of uninsured has helped hospital bottom lines. There's some evidence that hospitals are doing better now that more people have coverage, even despite the fact that, say, Medicaid isn't the greatest payer. It's a better payer than not having any payer. And so kind of the final section of our study, we really did want to try to figure out whether the Affordable Care Act and the big coverage expansions that we saw had any impact on emergency department use that we observed. This is kind of a difficult thing to do. Typically, when we try to examine whether a policy change that we can attribute certain changes and outcomes to a policy change, we either exploit differences in the timing of that policy change or in the geographies of who got the change versus who didn't. You see a lot of research on the ACA right now that are looking at states that expanded Medicaid versus states that didn't expand Medicaid, and that's what they use in order to try to understand how an outcome was caused by the policy change. So we don't have that in California. So what we did is we used a strategy that was used by some researchers in Massachusetts, where we looked at counties with very high uninsured rates among the non-elderly adult population in the pre-ACA period. So prior to the 2014 expansions, we designated certain counties as high uninsured based on what their uninsured rate was for non-elderly adults in the 2013 and prior period. And what we thought, the thinking there is that for those with a very high uninsured rate, they had more opportunity to be treated by the coverage expansions. And so what we wanted to do is we looked at their trends over time, and we compared their trends to the trends of counties that had much lower uninsured rates pre-ACA, and kind of the divergence in those two trends is what we attribute to the effects of the Affordable Care Act coverage expansions. And so when we did that analysis, we found, actually when we included all 58 counties, we actually found that the coverage expansions reduced ED visits, particularly for middle-aged adults 35 to 54. And so in other words, what this means is that in counties that, again, had those very high pre-ACA uninsured rates, their ED visit rates would have been even higher in the absence of the coverage expansions. But this is just because they, I'm just going to stop there. And so kind of to wrap it up, so yes, so we don't find any evidence that the Affordable Care Act caused increased ED use, right? The increasing trends we saw in ED use seem to predate the ACA, and in the analysis where we tried to, attach things to the coverage expansions, we don't find evidence that they significantly increased ED visit rates. That said, ED visit rates continue to increase. People are using emergency departments for care more and more, which again, due to, it's troubling from a cost perspective on the one hand, the whole healthcare delivery system really is in this space of evolving to have more people in coverage. And so the question is how best to care for all of those people so that they receive the care they need when they need it at the place where it should be delivered, and that can be coordinated and, have better outcomes for folks and also kind of manage the costs, or the growing healthcare costs in our system. And so kind of that leads us to what do we do, right? What, from a policy perspective, from a health plan or health provider perspective, kind of what can be done in order to say, make sure folks are using the emergency department as it should be used. And so that's why we're excited to have our panel, who are actually the people who are, working in emergency departments to have plans. So there are several initiatives, say under the Medi-Cal program, whole person care pilots, which we're going to hear more about today, redesigns to have people with behavioral health issues, those are mental health conditions or substance use disorders, who do comprise a fairly large share of folks that do use emergency departments, but how best we can manage the care of people that are using emergency departments. And so with that, I'll end and invite Caroline and our panelists up to the podium. Oh, thanks. Okay.
Thanks, Shannon, and thanks to our panelists for sharing their expertise. So I will, you have their names, but I'll go ahead and read their names and titles before we get started. So just to my right, we have Sarah Kate Levin, who is the Medical Director for Whole Person Care Community Connect at Contra Costa Health Services. And then next to her is Jennifer Rasmussen, Vice President of Healthcare Services, Molina Healthcare of California. And finally, furthest to my right is Renee Shaw, Attending Emergency Department Physician, Zuckerberg San Francisco General Hospital, and Professor of Emergency Medicine and Health Policy at UCSF. So we agreed on several questions to kick off the discussion, and we will engage in discussion for about the next half hour or so, and then open up the floor for Q&A for your questions. But let me begin with a broad question. Shannon gave us just now an overview of sort of a statewide overview of changing ED use in California. But it would be great to get your perspectives, and perhaps I can start with Jennifer for this question. From your organization's perspective, how has ED use evolved over the past decade, and particularly perhaps how have things changed since the ACA and the implementation of coverage expansions in 2014?
Thank you. Well, just for context, Molina is only covering people who have Medi-Cal or Medicare or covered California. So my perspective is going to be that of people with coverage, and specifically those typically underserved populations that have a lot of social determinants of health. So the data that I had at my fingertips to compare from our organization to what was presented in the report is a 3-year look back, so 2016 through 2018. And we're actually seeing that those numbers are coming down for all of our populations and all of our subpopulations as well. So if you look at the subpopulation of seniors and persons with disabilities, or those covered under the Marketplace Exchange, or Covered California as we call it here, all of those groups are coming down for us actually. So I'm pleased that they're not showing the trend that you saw in the report, which is still increasing, just not at the rate of those. And several things we can attribute to that. We've got several different programs that are really focusing on key subpopulations. So for example, those with the social determinants of health, we've got complex case management programs. We have an emergency department support unit that does specific member outreach to those people who've been seen in the emergency room, particularly those who've been seen for non-emergent conditions. And one of the things that we find is that folks don't know they have coverage, or if they know they have coverage, they don't realize they have an assigned primary care doctor. Or if they do know they have a doctor, they say, well, I don't have a ride, because they're not aware that they have transportation benefit. So we do a lot of basic education more on your healthier kids and younger folks who are using the emergency room because they don't know about the alternatives. Then we have more sophisticated programs that are really focusing on those high utilizers, people with behavioral health issues, people who have end-stage illnesses, folks who are homeless. So we've got programs that are really focusing on that, and we employ a variety of staff, social workers, nurses, LVNs, community health workers, to work with those folks to find out why they're accessing the emergency room instead of their regular doctor or their other covered services. We also find that there's a lack of knowledge about urgent cares and what their role can play. And in one particular example here in Sacramento County, when I first started at Molina, we had really high emergency room use, and people didn't seem to know. And as I was hiring folks who lived in this area, they said, well, that's because your contracted urgent cares are not where the low-income population lives. So then we had to go on a specific contracting strategy to make sure that we had urgent cares where our members lived, in those lower income, underserved areas. But even then, the concept of urgent care isn't one that's familiar to people, particularly people who haven't had commercial coverage. If they've been in the Medi-Cal system, that's just not familiar to them. So that's been our experience.
Interesting. Sarah, are there?
Yes.
I know we're going to delve more into these targeted programs. I'm very interested to hear more about the overall trends that.
Yeah, so from my context, I'm Contra Costa County Health Services. We're a county of about 1.2 million, and about 250 are Medi-Cal lives. We're an integrated health services department that has the health plan, Contra Costa Health Plan, which actually provides for 90% of the Medi-Cal lives. So the only other health plan insurer in our county is Blue Cross Blue Shield, and then a hospital and primary care FQHC system of clinics that spans the county. And so we have pretty much seen, in terms of our trends, there's in our public hospital emergency department, some slight increase in visits. But I think what we've really seen in the expansion is all of the huge numbers of our county that previously had no coverage, that now have coverage and are actively being engaged by the health plan to enroll in primary care. Our biggest, I think one of the big drivers for us is just the access at a timely way, because of the scarcity, quite honestly, of Medi-Cal providers in our county. It resonates with me all that Jennifer was saying in terms of sort of different ways in which our health plan And our county health system has really, as we brought in, a huge increase in people covered that we're the sole provider for, how do we navigate them, different programs to navigate them to care. There's been a huge lift across the system in terms of really trying to do outreach to people, engaging the transportation benefit, trying to navigate them, opening up phone clinics so that when they call the device nurse line across the county, regardless of whether they are in the health plan or not, that really tries to navigate to contracted urgent care centers, or to if the emergency room is not, or to a phone clinic visit if there's not anything available in the immediate future in the clinics.
So we've heard some about the location of urgent care, access to actually covered doctors or other health services outside of the ED, perhaps the complexity of navigating the system. Talk about avoidable visits, Renee, a little, and what does that mean? And what does that mean from the perspective of, say, the patient versus maybe a policymaker or a healthcare provider?
Avoidable visits is something that is talked a lot about in the media, and they talk about how people are coming for medication refills or all these things that should be taken care of elsewhere. I think it's important that we recognize that sometimes when policymakers or other people are talking about it, it ends up being kind of blaming the patient, saying, oh, they're going to the wrong place. When really you have to think about, does the system provide an alternative for them to go? Because if they don't, then of course they're going to end up in the ED, because that's the only place they can go. And so I think it's really important that we think about our ability to change the system so that we can make things more accessible for patients. And on that topic, I think the other kind of something that we, at least in the policy world, that people tend to think about is, well, then the answer is primary care. We just need more primary care, which is definitely part of the solution, but not the only solution. We have data showing that even for patients who already have primary care, we have patients who come in with private insurance, and a lot of them already have primary care physicians who tell them, well, your complaint is too complex, just go to the ED. I'm sure many of you have experienced that too. That's partly also due to some kind of cultural shifts in terms of our kind of instant media, instant gratification society, where we don't really want to wait, right? We have something that maybe 30 years ago we'd say, oh, okay, well, we're going to schedule you for some lab tests and then maybe a scan in a week or 2 or 3 weeks. And nowadays it's like, well, nobody wants to wait for that, just go to the ED. And that's not just the patient's expectations, but even primary care physicians who also feel like, well, I'm a little uncomfortable waiting, like the hospital will only give me a spot maybe 3 weeks from now, just go to the ED and we'll figure out today what you have. And so there are those cultural expectations also that are shifting that I think our healthcare system needs to recognize. And I think the other part about primary care is recognizing that there's only so much that primary care can do. So even when you think about, so we talked about our privately insured patients, a lot of their primary care physicians refer them to the ED. But even when you don't have primary care, I published a study just a few months ago actually showing that even uninsured patients, when you increase the availability of federally qualified health centers, it doesn't necessarily decrease their ED visits. And I think one maybe nuance that we haven't talked about in this particular report yet is talking about avoidable visits in the sense of, sometimes people think, oh, they're just, poor patients who don't have insurance that are using the emergency department inappropriately. But we also have on the other end of the spectrum, there's patients who come for maybe visits that, they're patients with resources that maybe just come because it's more convenient for them. And this, I think when we look at the averages, sometimes we miss things that are important. So we know from many studies, whether it's emergency departments or any type of healthcare, that geographic proximity is a really important indicator of how often you will use that service. So if you are located near a hospital or near ED, you're more likely to use that. And so something that is maybe a little bit of the elephant in the room is just thinking about the fact that we have a very market-based approach to healthcare in the United States. Hospitals don't pop up where the government tells them to show up, or it also doesn't, they don't pop up where the demand shows up. Hospitals exist where there is demand in terms of market demand, in terms of where there is a concentration of a high privately insured mix. And so you have oversaturated areas of places that have plenty of emergency department access. So when you drive, down, California, you'll see different stories coming to you. The two storylines you'll see is one where you'll say, come to our ER, the wait's just 15 minutes, or come, it's 10 minutes, or text us. Even, I will say even UCSF for some portion had a part that said, text us and we can save your place in line and you can wait at home and then come in when it's your turn, you know? But then you see other things in the media that say, oh, you know, the waits are like 3 hours, 6 hours, 8 hours, and both of those are true. And that is because we have a market-based approach to healthcare in the United States where hospitals can just locate wherever they want, and they will locate in places where there's a good patient-payer mix, and they will avoid areas where there's not a good patient-payer mix. So in some areas, your ER is a revenue center. That's where your paying patients come in. And in some places where you don't have paying patients, it's a cost center because you have to see patients regardless of their ability to pay because of the Emergency Medical Treatment and Labor Act. And so those are the two narratives that are going on, both of which are true because of the way that our healthcare system is structured. And I think that's just important to kind of think about as we look at these numbers.
I just want to comment on, I mean, I think that's, in our county, the closing of Doctors Hospital, which is located in the poorest area of our county, is a true example of that. While John Muir, is expanding a lot of hospitals in the more affluent areas of the county, and it's the exact same, those billboards going up, and then this closure that really led the only place for people to go in that community was the Kaiser ER, and so there's this constant conversation between our health plan and the Kaiser ER about, the access that has been incurred by the closure of that, the access problems that have been incurred by the closure of that hospital.
Very interesting. So as Shannon showed in her slides, there's a relatively small group of patients who account for a disproportionate share of ED visits. There's those who are heavy ED users, and I know both for you, Sarah, and for you, Jennifer, that your organizations have initiatives to help address that and perhaps bring ED level use down or make it for the cases that are more appropriate for the ED. Sarah, do you want to talk a little bit more about the work that you're doing, and then Jennifer after that?
So my role now is with our whole person care pilot, which is a 1115 federal waiver program designed for a 5-year period. All the counties in California could apply. I think it's up to 29 counties have some type of initiative. And the primary goal was, as stated, was to develop programs towards populations that are high utilizers of multiple systems within the full scope Medi-Cal population, people that are enrolled in full scope Medi-Cal. And so each county got to design whatever their program, their target populations that they were going to enroll in, what their program would look like. And there were two major sort of funding streams. One was really to evolve the infrastructure, both technology and relationships between systems outside of the healthcare delivery system. So partnering, there were some mandatory partners that included housing authority, or housing organizations, community-based organizations, social services organizations, the health plan. So that was one mandate, and the idea was really how do you improve care coordination in real time across the system to basically prevent avoidable morbidity as represented by high acuity utilization. So our program, and I think a lot of the counties really looked at what are the fundamental, people use the term social determinants of health, but also the more downstream, what are the unmet social needs that are driving a lot of this high utilization and morbidity that could have been prevented, right? And so what we designed in our county was a program where we really looked at sort of our top 10% of utilizers across the system, and developed a social needs case management program that involves interdisciplinary teams that are composed of public health nurses, community health workers, social workers from our Employment and Human Services Department, housing specialists, mental health clinical specialists, substance abuse counselors, and I think that's the team composition. So everybody's got their own caseload of people, clients, and we tried to match them with sort of what seemed to be the primary drivers of why they were in the high utilization group. And but then they work in interdisciplinary teams that are geographically located. So we have teams in West County and Central County and East County because we're a pretty broad geographic area. And the idea being that they would sort of learn the local resources that are within those different parts of the county and really be able to navigate the clients they're working with towards services. A huge part has been of their work. We have core services, so everyone sort of does the same amount of core services, which are really focused about identifying unmet social needs through an initial social needs risk screening, and then working with them over the course of a year to sort of work those issues. So a huge part of this has been the Medi-Cal churn too, that people are, they have to renew their Medi-Cal every year to stay eligible, and or if they've gotten presumed eligibility by going to an ER or being in the hospital, then if they don't follow up on establishing that care, then they don't get their Medi-Cal benefits. So that has been one of the primary, sort of that navigation with people. Then a lot of it is also navigation to benefits that they're eligible for but have not been able to secure, not didn't even know they were eligible for. So food, SNAP benefits. There's a lot of cases, clients who it's sort of they're in the process of applying for disability but haven't been able really to navigate that. So our social workers and our team case managers are doing a lot of that work. We also have a medical legal partnership with Bay Area Legal Aid, and that has been really helpful in trying for those cases that do need more legal help, to get things expunged for housing. So sort of that's sort of the day-to-day work of our case managers, and we're really what we're looking at is the outcome data, which we will have for our first year of really the program in the end of May, is sort of looking at how the people that are enrolled in our whole person care pilot program and their utilization compares to those who were at the same sort of risk but were not enrolled. So I'm hoping that we'll be able to have some positive results to say about that. But yeah, that's sort of where we're at in our county.
So stay tuned. From the perspective of Molina, you mentioned that you have both folks who are in Cover California and in Medi-Cal, so perhaps some of the churn is less acute for you, or is that?
Well, there's definitely the churn and the same basic thing about needing to re-up your coverage every year. And so sometimes, and there's also churn within the Medi-Cal system as well. So it's hard from a health plan perspective if your member is changing health plans every so often to really follow that person. And even if you're able to connect with them and build an individualized care plan around both their medical needs and their social needs, if you lose that member and then they come back 6, 9, 12 months later, it's hard to really have continuity of plan and follow through. But I want to follow up on something Renee said that I think is really important, the blame, if you will, on folks who are using the ED. And at Molina, we have programs that are really focusing on trying to connect with those members, find out why they're using the ED, get them connected to the services that are covered, as well as link them with community resources around those social determinants of needs. But a lot of times we do find that the system sometimes is the barrier. And you may be familiar with the report that the state auditor just came out with on DHCS and their oversight of managed Medi-Cal plans. And they talked about the lack of services, particularly for those with Medi-Cal coverage. So if you are an ER physician that's wanting to discharge somebody to follow up back with their primary care physician, but they're having trouble getting in to see one, they don't have one maybe that speaks their language, they're working full-time or working multiple jobs and they're not able to access that clinic during normal business hours, there is a system component that needs to be taken into account. And so part of what we've been doing at Molina is not just sort of your intense case management and care coordination programs that are focused on our members, but also our network and our system issues. For example, I already mentioned contracting with more urgent care centers and making sure that we are telling our members about the option to use urgent care as a benefit that's better than the emergency room. Also, trying to work with some of our larger practices and practice groups around expanded coverage, not just Monday through Friday, but having evening hours and weekend hours, because that's really critical. And again, you want to take away that convenience factor that people may see that the emergency room is there. And if you can see a billboard that says, oh, your local ED, it's only a 20-minute wait, and you think that could be your one-stop shop rather than going to a primary care, having them order other tests and things, you can see where that might be an option that people are looking at. And also, just to tie into something Sarah said, we have one of our areas. We literally have our network hospital next door to a Kaiser hospital, and Kaiser, rightly so, was a little frustrated at how many Molina patients were showing up in their emergency room. Well, our members thought that the comfort, the attractiveness, the quickness with which they got through Kaiser's emergency room was a benefit compared to the one that was right next door. But we still worked with Kaiser to partner around that, and again did that outreach, identified who's using the ER inappropriately, doing some basic managed care 101 navigation with those members, finding out that maybe they had a doctor that wasn't close to them or didn't speak their language, and really helping pair them up with a physician that hopefully could better meet their needs. But that being said, it's really not a one-size-fits-all, and I think it's important to identify that in California, what each county has in terms of resources and availability, whether it's the EDs themselves or the greater outpatient provider network, is incredibly different. So Molina serves Imperial County and San Bernardino County, and you may know San Bernardino County is bigger than the 7 or 8 smallest states in the US put together. So we're talking about a vast geography where if people have to travel a longer distance to go to an outpatient clinic that maybe doesn't have convenient hours, that local emergency room is attractive. So it's not just an urban setting for your millennials that want the quick response. It's true for people with chronic conditions as well. And a solution for Imperial County is not going to be the same solution as for San Francisco County. So I think that's something that policymakers and other organizers of the greater health and social services system need to think about as well. There's also not as many community programs to support people with non-medical needs in a county like Imperial compared to San Francisco, which is rich in social services.
And you mentioned earlier that you've started to see ED use going down. Do you attribute it to the work you've been doing to help folks navigate the complexity and increase access and improve your network? And how do you know?
I would like to say that, but I do want to caveat that the type of analysis that we do on healthcare data at the health plan is not the same as you do more in the academic setting where you're controlling for a lot of different factors. So while I would love to claim credit, I do want to caution that I think it has had a contribution, but it's hard to really measure how much. And because we often are doing multiple programs simultaneously, we had SB 1004, which is our palliative care program that we implemented over a year ago, where that's focusing on high utilizers, people using the emergency department for symptom management of end-stage illnesses. We've been doing whole person care pilots in Sacramento, San Bernardino, and San Diego. We've also launched the Health Homes program. It's a Medi-Cal intensive case management, field-based, at the point of care and meeting members where they are program that's also focusing on high utilizers. So it's hard to say that any one of those things, but we're trying to change the broader culture around healthcare and where to access care. But there are some real limits, particularly in more rural areas.
Sure. Well, it sounds promising. So let me ask you all finally, moving forward, we've heard and you've reinforced that EDs are an important place for folks to seek care, but it can be problematic. And moving forward, what else do you think that, and who, what else should we be doing? And a part of, sort of plans and counties, also the state, in terms of changing the healthcare delivery system so that EDs form or are in their appropriate role within the entire system. What else should we, where should we be going in the future in California? Are you, Renee, would you like to?
Sure,
start?
yeah, I have a few thoughts. I think one thing that is happening that is good in California that has not come through yet is in some private health plans, so Anthem, for example, in Georgia, they have started a program, and it's gone through a couple of states already, where they actually will refuse to pay for your emergency care visit if it isn't on if they decide that it is avoidable. So they will say, if you have this list of conditions, then we're not going to pay for that care. And from a policymaker perspective or from a health plan perspective, you could see that maybe that makes sense, right? As a taxpayer, I don't want to be paying for somebody coming in with acid reflux. But from a patient perspective, when you wake up in the middle of the night and it's 4 a.m. and you've got severe chest pain, you don't know if it's acid reflux or if it's a heart attack. And so that's a kind of a retrospective, it's Monday morning quarterbacking on, something that you had no idea about. Patients don't come into the ED with a sticker of their diagnosis taped on their forehead. They come in with a chief complaint. Mm-hmm. And so I published a study with my team a few years ago looking at and saying, is when you say that acid reflux is not covered, actually what's the chief complaint that people come in with? A lot of it is chest pain. And so when we looked at that, and we looked backwards and we looked forward, 89% of those chief complaints are the same of all ED visits and of the avoidable ED visits. And so you can't differentiate at triage what is an avoidable visit. So I think it's really important that policymakers recognize that that's not an acceptable solution, that we don't want to do that in our public health plans or in our private plans. I mean, we may not have as much power over private plans when it's happening, but just to recognize that that is a trend that's happening. I think also to recognize the importance of policy. And when Jennifer was talking about Medicaid managed care, you will have certain counties that will say emergency care is a carve-out, meaning that we will pay this provider group a capitated amount. We'll pay you this much per year for the care. But if they come to the ED, that's separate. We'll pay the ED on top of that because it's hard for you to manage ED care. But that means that provider group has no incentive to provide alternatives because why would they? Because they can just send them to the ED and it's not under their budget, right? And so that happens not just with emergency care, but with mental health care. Mental health care, a lot of substance abuse plans are carve-outs. Yeah. And so we actually see a lot of that in the ED because they're carve-outs and they have no place to go. I mean, in the 1970s, there was a huge deinstitutionalization of mental health, saying we're going to not have beds. They should be replaced by outpatient providers, but the outpatient provider part never happened. And so what you see is that you've got a lot of people with substance abuse needs. Like, again, what Jennifer was saying, I had just a patient a few weeks ago who was coming in from Crescent City or Eureka saying, I'm coming to San Francisco. He showed up in the ED because he didn't know where else to go because I want to get enrolled in maybe an opioid use kind of addiction treatment plan. And so there are you can see the interplay and it kind of all happens in the ED because they don't have access to that. And I mean, something that's also similar is thinking about dental care. So toothache and tooth pain is actually one of the top reasons people come in for avoidable visits. And that's something I can't do anything about. I can give you pain medication and antibiotics, but I can't take out your tooth. And so in certain places, you don't have dental coverage, and so people come and all we can do is give pain medication. So that's just not a great use of resources, and it doesn't help the patient at all.
I was just thinking, Renee, we were talking about how, so on our social needs screen so far, we have about 22,000 individual clients, which are 50% of them, that dental care came up as the as what they identified as one of their priority issues. And thinking about this patient we had last week, who's a 72-year-old woman with long-term schizophrenia, who's actually came to us from somewhere further north, living in her car, multiple chronic conditions, and so the place that she is going is to the ER, which can't really do anything for her in a reasonable. So I think from a policy perspective, really sort of being able to develop infrastructure that meets a lot of these needs is not currently a benefit through health coverage. And, this is sort of what the Whole Person Care pilot program is supposed to be looking at, really, is if Medi-Cal, CMS starts funding these non-traditional health delivery services, does it actually improve health and reduce overall costs? But we're looking at sort of, as long as we're staying in these pilot programs and there's not real policy changes that come out of that reimbursement infrastructure, my fear is that these are gonna, it's gonna go away. These types of developments that are the health home, all these initiatives that are really trying to broaden the landscape of what gets covered under and considered as a health benefit.
Thank you. Do you have anything you'd like to add right now, or should I
pile
just?
onto the carve-out discussion
Oh,
for a
yeah.
moment.
Of course.
So as a Medi-Cal, primarily a Medi-Cal managed care plan, Molina, as other Medi-Cal managed care plans, has an obligation to coordinate all of the Medi-Cal services, whether we're getting the premium for it or not. So we are expected to help coordinate and manage the behavioral health, the dental, all these other little waiver, targeted case management, IHSS, all of that. And while that's worthy and that is doable in a theoretical way, we often don't get the data from those other entities. So it makes us difficult to identify those folks that are, for example, using the emergency room because they're not able to access their behavioral health services, or we may not even know that that person had a behavioral health inpatient admission because that particular county does all retrospective review and we don't get a data feed on that in real time. Part of our ability through some of our specialized programs is really to seize on the opportunity when it faces us. So we now, in some of our large volume hospitals, we have on-site staff that when a member's in inpatient setting or not as much in the emergency room, but we can send someone to the bedside to meet with that patient and find out what brought you here today. I'm your coach from Molina. How can I help you? We don't want you to come back here. And for the most part, people don't want to be in the emergency room. And so, but they often don't know. And I think as there are new discussions about what more to carve out of Medi-Cal, for example, all of prescription drugs and things like that, it really makes it difficult for the health plan as a single point of contact to really have the information, be able to put that together in a meaningful way so that we can really figure out what's driving our members to use services or to not use services. Because sometimes that's as important as anything, is that person who maybe had one encounter with the healthcare system and they had a serious condition, but yet they're not getting any follow-up care, that's your person that's going to end up in the emergency room, and how can you intervene on that at an early point where you can bring other resources, hopefully, to prevent that. So that's my soapbox on the carve out.
Let me open it up for Q&A. Please remember to wait for the microphone. We are webcasting this, and so your question will be heard if you speak into the microphone.
I know you didn't mean it this way, but it's coming off as a very frustrating experience to deal with all of these factors. And I was wondering, there are a lot of efforts to incorporate peer support specialists, and it's been found that they reduce the influx and the return visits by just educating and taking care of some of the resource needs and some of the other things so that they can choose to divert to a different urgent care or something rather than ERs. I was wondering what your thoughts are on the use of peer support specialists as team members.
Thank you.
So I think we have a program called Spirit Program, which is a peer support for mental health conditions. So all of them have been in the system or had family members, and then do a certificate program which is really appreciate your question, because I think that and then the community health workers as well. We're trying to hire for people that with lived experience, but there's bureaucratic stuff around getting the minimum qualifications reduced. But that's been another one of our hopes, is to sort of make changes within our county hiring structure to start working towards how we bring in people with lived experience as the support people for these types of programs as we develop them. So I know LA in their whole person care project has made a lot more progress with changing that at the county hiring level. So they've really committed. Most of their workers within the whole person care are people with lived experience. Thank you.
I'm a nurse practitioner, and I work at an FQHC as well as a university hospital as a registered nurse. And so I'm like in the middle of this sort of on a day-to-day basis, and I'm thinking about how the PPIC, more importantly, I think, brings together people from various organizations. Like I'm thinking of Uber and Lyft, for example, just off the top of my brain, because transportation is such a big issue. I'll just leave it at that. The other thing is, I wonder, I'll say that one point, and the other thing about location, I've always imagined that organizations like Goodwill Industries, where lots of folks who are under pressure from the social determinants of health do shopping, and folks who aren't also, but you see that. And I wonder how an organization like that could help us address healthcare where people shop, where they live, where they do the thing, they go to those places. They hang out in front of, it's not a negative thing, it's just that's what they do. And if we put clinics with healthcare providers who want to serve in those areas, and utilizing the space that's already there, the rented space that's already there under an organization, an umbrella organization, what would that look like?
So was that a
Comments on bringing care to people where they live?
Well, I guess my question, one thing would be, was PPIC, did we invite Uber, Lyft to an event like this? Did we reach out to CEOs of Sutter, UC system, the top level people who look at the organizations? And that would be a way of helping to bring things together. Goodwill Industries. Just the places where people live and inviting them here. That would be because I think healthcare providers can't do this alone.
Right.
Healthcare organizations cannot do this alone. This is not our baby. This is our societal baby, right? This is our, and so I think about that is how do we work together with other partners? My wife happens to be a psychiatric nurse practitioner as well, and talk about the need for coordination between just downtown Sacramento and Yolo County, for example.
I guess I can speak from the kind of the PPIC perspective of who we try to engage with. I mean, for our events, I do think we have a pretty wide ranging, although to your point, how wide ranging that is, if folks say are an Uber or something, I don't know that they would be on our, targeted mailing list unless they had selected in. And so to what extent we can do outreach in policy areas, beyond maybe some of the usual suspects, I think is something for us to consider. Your point about, say, transportation benefits, and I think it got brought up by the panel, it does kind of make you think about engaging other actors, whether it's, policies to help people connect with Lyft, which I'm sure on the one hand, to the extent transportation is a covered benefit for Medi-Cal, I'm sure plans and other places do try to figure out various ways to try and make that happen. But it's interesting to think about maybe what the responsibility or the role that some of these private actors can play when we're talking about what the social needs are, right? And I think that's something that, is evolving, but it's a good point, and we can kind of consider that more.
Well, and if I could just add quickly, I mean, we are, as a health plan, engaging with folks in the community around kind of shared goals. So for example, in Riverside, we have a partnership with Salvation Army, and they're doing some programs around homelessness. So we've set up what we call a Molina closet there, where as part of our employee giving and volunteer arm of our organization, have stocked the closet with clothing and hygiene supplies and some other things like that. We've also done some partnerships with schools around kind of basics, kids who maybe aren't going to school as frequently because they don't have the basics, so backpacks and shoes and some other things. And now with the governor's new focus around children, we're actively exploring how can we bring some immunization clinics and other things to some schools, particularly in those neighborhoods where our members who, because they're Medi-Cal, are low income and may not have access. And while Molina hasn't worked with Uber and Lyft as part of the expanded transportation coverage, I know many other Medi-Cal managed care plans have done that, and I think with some mixed success. So I think there are places where folks are dipping their toe further, or trying to get past their toe into partnering with those organizations, but sometimes implementing the good ideas is complicated.
And I would just add to that, so we actually started a contract with Lyft for the transportation, whole person care, to do the rides, and we're sort of moving, our health plan's moving towards that, which, so I think we're gonna have an integrated, coordinated system. And another partner we sort of worked with, which has been very generous, as part of our program, they can get a free cell phone and 6 months of a plan, and Sprint is giving us all those basically for free, with the idea is that they'll transition to a low income plan, but that has been a wildly popular and engaging item when we're trying to get people enrolled in the Whole Person Care Project.
Thank you.
Hi. First, let me start by thanking PPIC for another great research study, and thank you to the panelists. Appreciate that. So I represent the California Hospital Association, and specifically our small and rural hospitals in California. So Jennifer, I particularly appreciate your remarks, because when we even talk about Uber and Lyft, doesn't exist in rural areas, so you're having to come up with something different about transportation. But my first comment has to do with policy decisions that we make that further increase or exacerbate an impact on our ERs. So this year, January 1, started the implementation of a new law, the Homeless Patient Discharge Policy, which essentially puts our hospital ERs right smack dab in the middle of social care, because we touch those people. And I get that we touch those people, but putting so much responsibility on our ERs to offer food, clothing, transportation, vaccinations, infectious disease screening only encourages people to come back to the ER for those things. We are hearing anecdotally that people are coming in 2-3 times a day now because they know you have to offer them food. So we need to think twice about good policy and how we make that. But two, I would also offer to PPIC that that policy change may be a good research point in time to see if there is an increase in ED visits specifically by the homeless, because now we have to identify them because of a policy change. So I would offer that up.
Thank you. Reflections on policy decisions that state lawmakers have made, or federal decisions perhaps that have made your jobs harder or easier?
Well, if I could just take that a step further, just to the argument, if you will, I think while there's definitely a role, for example, health plans, so you're talking about the role of the ER now in these more complicated social services types of things. Similarly to the health plan, as I mentioned earlier, kind of coordinating a wide variety of things that are outside of our control but may have Medi-Cal dollars attached to it. There's a lot of talk about expansion of other sort of social services that are driven by the health plan. And when I went to public health school, I won't tell you how long ago, I mean, social determinants of health was a niche topic that you didn't hear about outside of public health school, but now it's everybody's favorite little lingo. And there's a lot of talk about putting more onus on the health plans to be delivering services like food and housing, and they put it under different names, in lieu of, and supportive services and all of that kind of thing. And while there may be a role for the health plan, I think as a society we need to say, is the health plan or the ER the appropriate vehicle to supplement the lack of other social services in a community, particularly in those underserved communities, either because they're underserved in urban or underserved because they're rural. And I can't help but think of in the 80s when the lottery was going to be the solution to funding schools, but what happened, the legislature, started chipping away because, there's all this money coming in, and I worry, could we be entering in with good intentions something similar where we drive more of those social service funding through places like the ED or a health plan or whatever else, rather than focusing on how are those unique organizations that are in the community and experts at providing those kinds of services, do we support them? And I'm not coming out on one side or the other. I just think it's something as taxpayers, as policymakers, as citizens in a community who look around, what do we think is the best way to address some of these broader social questions?
I also just want to comment on that because I think what you bring out also can exacerbate existing disparities, because if EDs and hospitals tend to be located in places with good patient-payer mix, and then you have a few sole ones that are providing services in rural areas that now actually have to disproportionately provide those types of services to their patients, then it's even harder for them to financially make it through. And so then there's even a more incentive for them to exit the market completely, and then those any services don't exist. Yeah.
In thinking about what Renee was talking about in terms of it being market-based and hospitals being built in those areas where there's more insured people, how do we provide incentives for the construction of these hospitals? Like, what does that policy solution look like?
I think that there have been a few things that we can consider as a state. So when we think about EDs, a lot of times in this report we've been talking about hospital-based EDs. There is a phenomenon of freestanding EDs, which actually has been used so I'm from the state of Texas. I was just there last week. And in Texas, there's like no regulation for much. But you can pretty much build a freestanding ED wherever you want, which means you don't have to have the upfront cost of building a hospital. And they also tend to locate in really, just on each side of the highway, next to the steakhouse, there's an ED. And it's true. And that's a misuse of where freestanding should be. But I think there's a place for maybe considering how we can provide in rural areas. You may not need, a 450 bed or 150 bed hospital, but you do want to provide emergency care for people and stabilize people, and then be able to at least have them a place where they can go, which is not 2 hours from their house, and at least maybe a helipad or something like that. So I think that's something that maybe as a state we can think about in terms of access. The federal government actually does provide reimbursements for critical access hospitals. There's different funding mechanisms for that, and I think as a state maybe something that we can consider. But in essence, it is a really big problem, just the way that our healthcare system is structured, because there's no incentive for, when we talk about, why don't we start clinics, outside of Salvation Army or Goodwill? Well, it's either the state or the feds or no one, because the private health, Aetna and BC, Blue Cross Blue Shield, they're not going to say, hey, let's do that, because they have they probably have very few percentage of people beneficiaries who live there. And so that is a fundamental problem of our healthcare system, and something that until we are willing to address that deeper issue, we will be stuck with kind of dealing with the symptoms of, I think. But there's little things we can do in the meantime.
BJ Bartleson with the California Hospital Association. I do emergency services, so thank you very much for putting this on. I think most of you are aware we're trying to work on solutions, alternate destination to be one of them, and I think we're struggling right now with how do we define a sobering center. Behavioral health and crisis stabilization units are a little bit more familiar to us, and we're getting our hands wrapped around how we license those, and they seem a little bit more plausible. But we have a number of sobering centers across the state that have not really had any type of oversight. But yet we are seeing through the community paramedicine pilot projects through OSHPD that there is particularly from the FQHC in San Francisco, that this is a very valuable model. And so we're continuing to look at it from a policy perspective. So I would like to hear from the payers and Dr. Renee, what do you think about sobering centers? And could this be really another opportunity for us to get the patients to the right place at the right time? And if they need an ED, they need an ED. They can still go to those places afterwards. So just your thoughts on that.
Thank you.
So as part of, originally in our plan for the whole person care project design, we were actually, the sobering center was going to be what we did, one of the side projects where we were going to develop a 20-bed sobering center, because a good amount of our public hospital ED visits are, we figured that we could do probably up to 10,000 visits a year. We're in the 5-year pilot project. First year we dealt with a lot of NIMBY issues in finding a site, and then the subsequent sort of planning. Basically, we weren't able to do it within the time frame of the budgets, but that's something and then there were these questions about how highly regulated being able to do an alternate destination is at the state level. We were really concerned that we were not going to be able to sort of get the diversion in a way that was feasible. But I would love to see sort of state policy allow for more development of that in a more timely way.
As a practitioner, I haven't done research in the area, but as a practitioner, I love sobering centers. I mean, we have a lot of patients who, sit in beds for 12 hours, and this is, in the United States, we keep, and these patients, most of them need to be in beds because they can't walk, but, they will, in other places, you can kind of hot seat patients, meaning you see a patient and they have like a sprained ankle and then they can go wait outside, but we don't have that system. It's culturally like kind of not accepted in the United States. So you basically get the bed for your entire stay and no one else gets to use that bed. And so we have a lot of patients who are just sitting there for 12, 16, 18 hours.
We'll wait for your report. Well, and I would just comment more generally that I think there's a lack of behavioral health and substance use particularly for the populations that we serve, Medi-Cal population. And again, we've got kind of a weird carve out thing where if it's supposedly mild to moderate, it's our responsibility. And if it's severe or inpatient, it's the county. So that's overly complex. But, particularly in our rural areas, the access to child psychologists, child psychiatrists, whether we're talking about treatment of ADHD or early drug use or, other behavioral problems, there's just a general lack of that. And just deciding, well, we can increase the amount people will pay and therefore more people will take it. But if you're in an area where there literally isn't a child or adolescent psychiatrist in 60 miles, it doesn't matter how much you're going to pay. That's not going to be enough to have somebody pick up their practice and move there. So I think there's bigger discussions about how do we increase access to those services, because until then you'll end up with folks using the ED because there's no other alternative, and people get to that point of crisis where that may be the most appropriate place for them in that moment.
Yep.
Really great conversation. I'm a couple of thoughts. I'm kind of anxious to get into the data again, mostly because if we think about the patients as sort of the canaries in the mine shaft, they're there not for just solely individual personal reasons, but for environmental reasons. So good example is asthma or COPD, those spike when the air quality is bad. And I would really love to see the data teased out for those things. And rather than the health system feel like it's solely their responsibility, to put that back out to the community and public health and other systems. So that's just one suggestion. I think there are a lot of emergency room visits that fall into that category. And then the second thing is we're moving toward a time when 1 out of every 5 economic dollars is going to be spent in healthcare. And I think it's about time we start thinking about planning it. So I happen to know there is no central repository in the state for plans around the location, siting requirements and all of that for health facilities. And I think that is very, very costly, and costly for those that bear society's burdens in a big way anyway.
Yeah.
And so I'm wondering what you think about coming back to a time when we did try to do some planning in the 60s and the 70s with health systems planning, what you think about what planning would look like and what would it address?
I mean, I think as a start, the fact that hospitals, the supply of hospital has nothing to do with where the demand is. Like that's, people in other countries are like, oh, really? They just can pop up. I mean, I have friends who work in the planning departments of like Gap or, Old Navy. And like, it's the same thing in hospitals. They also have those departments that decide where they will locate based on, where the profits are. And the fact that that's what determines where hospitals are or where, alternative sites of care are or urgent cares. I mean, it's a little bit insane. And so, I very much think that there needs to be a government role in determining where this should be, because it's also bad for patients when there's too much care, because there's iatrogenic procedures. There's a lot of like downstream effects when you basically have a fixed volume of things and too many providers. Like providers don't get the expertise that they need. So I think that's something that I don't know what policy is actually on the table for that. So I'll defer to PPIC folks or people who know more. But I mean, I think fundamentally that's something that I think there's more of a palette for that now, at least in terms of people who recognize that the kind of dysfunction of our health system is more the rule rather than the exception. I think that media has played a lot of, helped us understand that. But I actually don't, outside of kind of major shifts in how we deliver healthcare in the U.S., I don't know what other kind of state policies are on the table or anything.
Honestly, I don't. I mean, the CHA probably has much more information on what sorts of policies dictate than I do in terms of the policy. You know, we do have a statewide office for health planning and development, which obviously plays a whole host of roles, right? From earthquake safety to all the licensing and that sort of thing. That said, I mean, Renee made the point, our healthcare system is a large part of our healthcare system is a private marketplace, and to the extent that that drives decisions, you know, that's how it works. And so what is the appropriate role of government in healthcare, I think, is something that has always been a question. And I think since, say, the Affordable Care Act has kind of pushed that even further, you have folks at the federal level now that are wanting to push the conversations, and at the state level even further. What is the role of government? Who pays for things? And if, as we evolve in that way of who is the payer, I think that will also likely evolve where the providers go, right? Like, so if, you know, to the extent if the government is the payer for 80% of all expenditures on healthcare, then one would think that their role as a planner, which includes what types of healthcare providers should be located in what kinds of places, how do we get providers to locate? I mean, there's a lot of work that gets done there, loan repayments, all this thing to get providers into other areas, and those are ongoing. And yet there are these systemic factors that continue to kind of have things kind of keep the status quo. It does feel like right now there is some shaking up in terms of what our system looks like, at least on the coverage side, I think, from the ACA, and perhaps that's going to continue evolving. But it's a really good point.
I do actually, it brings to mind, though, there are ways that we can be involved in structuring the healthcare system that aren't necessarily by changing our the way we deliver care. And so one example is the extent of government involvement in the allowing certain mergers and acquisitions. And so on the federal side, the FTC, the Federal Trade Commission, has not been very active in kind of disallowing things to happen. But we already see in California, as you have more monopolistic behavior and larger provider organizations merging, that there are implications in terms of where they provide services. And I won't be more specific right now because we're being recorded, but I can give you ones later. About where, you know, when you merge, then you can say, we're going to provide the same number of beds, and then the number that we report to OSHPA is going to be the same, but we're actually going to just close this one here, right? And so it looks like there's the same access, but there's not at all in terms of geography. And so there's ways that you can, I think that the state could be more, and that's actually maybe not state, that's maybe a local decision, right? So when we go to the Board of Supervisors, and whether the Board of Supervisors allows that to happen or not is a way that we have power to allow things or not.
I think there was a study from Maryland that looked back 10 or 15 years to a bunch of different mergers to look at how did that change access to care and
decrease access, increase costs.
Yeah. So that's one model.
I'll take your comment quickly,
Yeah,
and then I
just
think
a
we're going to
very
have to wrap
quick
up.
comment, and the answer was absolutely correct. You know, right now we operate in a world where politics plays one role and policy plays another role, and the two don't necessarily come together. But I think if we're going to move forward, we've got to think less about who's going to pay for the care than where the care is needed. But then it is important how the care gets paid for, right? So it's just like this continuous circle. But if we're right now just basing on who's going to pay for the care, then that's where you get decided. And then I'm just going to add the comment that if we continue regulating hospitals the way we regulate hospitals, no hospitals are going to volunteer and say, oh, I'll open one in this place because I want to be highly regulated.
So we need to wrap up now. It's nearly 1:30. Let me thank again the panelists for sharing their expertise. Shannon for giving us a clear overview of ED use in California, and for you all, to you all for coming. Thank you.